Welcome to Discussing Fitchburg Now. I'm your host, Sam Squailia. This week's show, we are talking with Dr. Jared Toman from Heywood Orthopedics at Heywood Hospital in Gardner. Welcome.
Thank you so much.
Thanks for coming on.
My pleasure.
Okay, so we are talking about orthopedic surgery options, perhaps that better your quality of life.
That's always our goal. Whether these things sneak up on you slowly over time or whether they happen as the result of a step you didn't think was coming, yes, our goal is to get people back to their quality of life, but more importantly, give them options whenever we can give options about how we get there. I don't think that that a one-size-fits-all approach is necessarily good or productive, so we like to understand what people are looking for and try to match what we can offer to what they need and expect.
So you are an orthopedic surgeon,
yes, ma'am.
Correct? At Heywood Hospital.
I am. I spent 13 years in the United States military. I had my first practice in Georgia, and since my...
I get that military vibe from you.
I've let the hair get a little long, but my wife's family is, I think, 15th generation Massachusetts, so when we had a bunch of kids, I said it was time to come back. And
it's my favorite state also.
It's pretty good. We kind of like it, but we're very happy and feel privileged to be back practicing in Massachusetts.
Nice. Yeah. Okay. So, what are your specialty? Appears to be hip replacement.
I replace a lot of. My specialty is joints. I replaced hips and knees and shoulders. I do rotator cuffs. I treat a lot of young athletes, and et cetera. But I wanted to talk a little bit about hip replacements today, because I think that's a good way to sort of broach, how a lot of the smaller, hospitals, especially out our way, are really responding to the patient as the healthcare consumer, maybe in a way that people think they can only get at an unnamed city about 47 miles to the east of here.
An expensive, faraway city.
Exactly.
You can get the same work done locally.
Correct.
And just as good a quality, if not better.
That's our goal. I think we only get better if we have somebody or some institution or some standard to compete against and to hold ourselves against. I think that there's a narrative that's present in north central Mass, or where I live in southern New Hampshire, where people think that they have to go to the quote-unquote big city to get the right care. And I think maybe 30, 40 years ago, that was not unfounded. I mean, in the distant past, smaller hospitals sometimes were where physicians who weren't great kind of went to, hide a little bit. And big cities were where the innovation was happening. They had the best technology, they had the best processes, they had the best people thinking about the problems of the patient. But over the past, certainly, the 10 years that I've been in practice, and maybe 20 years since I've really been doing my training, technology and what's available at all levels has really flattened that playing field. And what that's allowed us to do is, as doctors, as hospitals, as care providers, is stop focusing so much on the nuances of every individual piece of care and start to respond to the patient as a consumer. And I think that's really what people are looking for these days.
Like, what do I want out of my surgery?
Correct. Well, not just surgery. Before we even get there, is that even appropriate? So a lot of time, I'm an orthopedic surgeon. I like to operate on stuff, but surgeries is not always the right option, and honestly, rarely is it a place where we start, only in cases of extreme need.
So you might start with diet, if you're overweight, or you might start with other therapies. What's some other therapies that you might start with rather than just going straight to a joint replacement?
Well, let's talk hips. I've got some slides about the hip.
Okay.
The first thing we try with hips is to get people in the best shape that we can. And yeah, you're entirely right. That involves physical therapy, that involves gait training, even very simple things like changing the environment of the home to make it easier to navigate from point A to point B. We then try, we scale it up, maybe add medications when it's appropriate. I was just listening to Ms. Brent's very powerful story, and I think that's a very important, cautionary tale as to why I and a lot of other good surgeons try to minimize narcotics, both pre and post-surgery. But physical therapy, medications, changes in lifestyle, just trying to optimize a healthier way of living before we take that big step, that big physical and cognitive step of putting in one of these.
So what you have here, this would be a total hip replacement kind of set. Is that correct?
Most of it, most of it, yes.
This is a partial hip replacement set?
Well, no, it's some of the parts. You know, I think when people, you know, I have these models in my office, and once we do get to that step of saying, hey, you know, we look at the x-rays. I always love to look at x-rays and MRIs with my patients. Like, for instance, a lot of people come in, you know, they've read a lot of big words, they've been on the internet, they, you know, they still are very sort of confused about what's going on with their shoulder or their knee. And even if they haven't looked at an x-ray or an MRI before, a lot of people can get it. I mean, we can go through, we can show them the anatomy, we can say, this is what's not working. And
here's
this
a
is
normal x-ray. This is what it should look like. Here's your x-ray.
Correct. Correct, and I think that makes it very personal and gives them a real image to latch onto as we move forward in the care paradigm. But I think one thing a lot of people do is they tend to focus on what we take away. They say, when you talk about hips, they say, how much of my hip will you be taking away? Just enough, you know. I can give you exact figures, but it's
the problem area.
It's very, well, yeah, but it's very hard to relate to. And they ask a lot of questions about the implant. Oops, excuse me. This is one of the implants. And
so this goes in this goes in your femur?
Correct. But when you drop it on the floor like that, that's how it winds up in my hands for a demonstration like tonight.
Yeah.
But as you can see, all it is a simple chunk of metal. And it's not the chunk of metal that you want to worry about.
This goes like here.
Yes, ma'am, you're exactly right.
Yeah.
It's not the chunk of metal. It's the person putting in the metal. It's how they approach it. And it's the environment where you get your care.
So how does this work?
Oh, that's not, well, that's...
Does it not go together?
No, they don't. These are just all pieces of plastic. But if you can imagine, this goes in the femur, there's a metal cup that goes in the shell and the acetabulum, and it just kind of, and there's a ball, and it just kind of sits there. I'm sorry, I should have brought in a real one, but I didn't drop that many components. But you know, but like I said, a lot of people focus on what's going in, and they focus on the surgery itself, and I think in some ways, that's not quite the right thing to focus on. The surgery is only it only takes me, you know, to do a good hip replacement, takes me about 45 minutes at this point in my career.
45 minutes?
Well, yeah, about that. But what you want to focus on is how well you're prepared for it, how well you're able to get through it, what your plan is afterwards, and then it's sort of especially for joint replacements, it's a longitudinal relationship between me and the patient and the therapist that sometimes it's hard to do on a remote basis. You know, so if you are traveling,
if you have to travel to Boston every other day.
Correct. And I feel you do lose something in your relationship with the surgeon. The surgeon cannot as easily talk with the therapist. I have my therapist in my office, and she sees all my patients.
And when you say therapist, you mean physical therapist?
Yes, ma'am. I hate to say it, but the outcomes of, let's say, a total knee that this little guy gets put into.
That's a knee?
Yeah, it's a little plastic insert. The results, you know, what I do as a surgeon is probably a little bit less important than what people do downstream with therapy. Because if you just sit there, you're going to lock up tight and you're not going to get the outcome you deserve.
So, you know, when it comes to joint replacement, in my experience, it seems like everyone over the age of maybe 60 that needs a knee replacement or double knee replacement or hip replacement, they have put it off for 10 years, 15 years. It's been hurting them for forever. And finally they do it, and then they say, I wish I didn't wait. That's what they all say. I wish I did this sooner. Why did I wait 10 years for this? Is that common? Would you say?
Fairly. But it's also...
People seem afraid of the surgery.
It's a big cognitive step to say my joint is no longer working. Would you do surgery? Would you do damage to my body, essentially, which is what surgery is, in hopes of making it better? Some people arrive at that a little faster than others. You know, I had a slide up there before. I don't know if they can they can go back.
Oh, with the zebra?
Yes.
Can you pull up the zebra slide?
Zebra slide.
Matt, please.
So, you know, to your point about waiting.
That horse got the wrong leg.
He did, but I love this cartoon because it illustrates so much, and also just about what you just said too about waiting. There's nothing wrong with waiting, but what we leave behind is what more important than what we take. And the longer you put off a joint, the less the tissues we leave behind, like the joint capsule, like the muscles, the less those want to function the way our patients want. So it's never an emergency. But
it feels like a quality of life.
There's a point at which you got to go, because go back to that slide again if you wouldn't mind, if you can. Sorry to be so demanding. Because what we're all looking to avoid is precisely this. So this is one of my very first joint patients I did in the military gave me this. And I'm glad he did well because he knew a lot of important people and could have made my life unpleasant, but he was a great guy. But he brought this in and said, Major, I'm really happy with my hip, but I thought this was funny. And I looked at it, and it is funny. But I think this illustrates a lot of what we're trying to avoid in elective orthopedic surgery and why a lot of patients choose to maybe go elsewhere. This is a horse. He got a zebra leg. A zebra and a horse are very similar, right? That leg probably works just fine, but it didn't meet that horse's expectations for what he'd have afterwards, right? So someone just said, I'm going to give you a new leg. It works, but it doesn't look quite right.
Not entirely, please.
Exactly. And so that's, that's why, we really take our time to explore the right options with people. We don't just, hey, welcome. Hey, I'm Dr. Toman. Welcome to the office. So we'll sign you up for a new hip. That's not how it works at all.
It feels like in the past, maybe 20 years ago, you used to hear stories of, I got the hip replacement. But it's creaks or whatever, and it only has a lifespan of 15 years or 20 years or whatever. But it feels like today that the lifespans of these materials are much longer lasting, and the recovery time is less, and the quality of life is just increased exponentially after surgery.
Yes,
that's what it feels like to me.
Well, that's why I started doing the anterior approach to the hip. The old posterior approach to the hip worked just fine. It worked when Sir Charnley invented it in the 1950s.
Sir Charnley?
Yeah, he's an old English guy who did the first hip replacement.
He invented the anterior approach?
No. He went in through the back.
The posterior. So the posterior is going in through the back of the hip.
Correct.
And the anterior is
going in through the front.
Going in through the front.
We have a slide on that in just a minute, but it works fine. Just like a
here we go. Can we pull
just like a carbureted engine works fine, but it's certainly not as good as a fuel injected engine, or with a hybrid boost.
So when you cut through the front, it's faster, shorter hospital stay, decreased cost, and has scientific study support.
Yes, ma'am. But it is also turning the conventional hip replacement on its head. And when I was in the service, I did a little mini fellowship in learning how to do these from one of the real pioneers of the procedure down in Savannah. And I did a lot of them with him. But the first time I did one of these myself, I did not sleep the night before, because you're operating next to some larger structures. It takes the entire surgery, turns it upside down, and you really got to get your head around it. Now,
are we talking anterior or posterior?
Correct. Going from posterior to anterior. Okay. So that's why not a lot of people do it. There's a very steep learning curve. And if you're in the middle of a very busy practice and you've been doing the posterior hip for 20 years,
you're not changing.
You're not changing. You're not. And it takes a specialized table, but I'll tell you, now that I'm getting close to I'm over 500. I don't know how far over 500.
500 surgeries? 500
anterior total hips. Yes, ma'am. Okay. I would not go back. It gives me the best control, the best exposure. It gives me the best precision. I mean, I can get limb lengths within a millimeter of the patient's other side. And with the old techniques, you sometimes can't. There's some very
limb lengths, no, when you talk, that's correct. Sometimes you've seen horror stories where people correct. Are shorter on one side and correct. They walk funny.
Imagine walking around with one shoe on and one shoe off for the rest of your life.
Oh, that would be awful.
That is not quality of life.
Right.
Your hip pain may be better, but you're not happy. And so I think the more control I have as a surgeon to give people what they expect, the better it is. So, we do through the anterior approach. I have got another picture there, if you want to advance one more slide. That shows one of my pictures from the OR, maybe.
Can we skip the next slide, Matt?
Well, anyway, it shows us a picture from the OR, and you'll see that my incision is barely large enough to get the implant in.
It's a small incision compared to a posterior.
7 centimeters.
That's 7 centimeters?
Correct. And
I only know inches.
Yeah. So it's a 7 centimeters, 7 to 8 centimeters, depending on the size of the patient. And we don't cut any muscles to go in, and that's really what differentiates. It's not that you're going through the back of the front, it's that you exploit natural planes and tissue to sneak into the hip.
Just moving muscle.
Correct.
Instead of cutting it off the bone.
Correct. And that's why I can get patients up the very next day, or the very same day, and get them walking around. Now, there it is.
Here we go. Can we pull this up on the screen, please?
So that yellow circle you have there is just about the size of the patient's acetabulum, or the cup in which the native hip sits. And so we've gotten it down to being able to just get it just barely large enough to do our work. But because we use a real-time X-ray machine, we have a lot of information about where these components are going and a lot of precision as well.
A real-time X-ray machine.
Yes, ma'am. Yep.
That sounds very technological.
Nah, it's just a C-arm. It's been around for years, but it has been hard to use for hips because, you know, the patient on this is lying on their back. They're not on their side. They're not, you know, on their stomach. They're not in a weird angle.
So in the anterior approach, you lie on your back.
Correct.
On the operating table.
Correct.
And you're out cold.
Yeah, you can be. Some people like to just have a spine. I just do all of them under spinal. And
you do?
Some people stay awake. I operated on a physician friend of mine at my previous practice. He wanted to stay awake and watch with me, so I have 2 screens. And yeah.
Cool.
Yeah, yeah. But I would also say too that even with all the new technology, even with this, you know, brand new titanium hip that's coated with this stuff that fools your body into thinking it's bone, so it grows into it.
So it
you know,
grips.
Even with all the best techniques, this is still replacing a part of your body. There are still limitations, and that's why whenever possible, I like to, you know, as you said, I like to help patients delay this as long as they can. But you know, when, like for instance, I saw a guy today who's fairly young, had bad arthritis. His main complaint wasn't pain; it's just that he couldn't move his hip anymore to walk. Maybe he's not the best candidate for a total hip because he has a very physical job, you know. So maybe we put it off until he's hurting.
Now let's just back up 1 second. When you say total hip, that means the cup that goes in the acetabulum and the
stem.
The stem.
And the ball. And what we have on the screen right now is a total hip.
Oh, this on the, oh, can we pull this up?
Yep.
This is good.
Yep.
So this on the right is an X-ray of a total hip replacement.
Compared to the patient's other side.
You got screws?
Correct. Well,
so that the thing that holds the cup.
That particular bone was a little bit loose. I don't usually use the screws, but I like this picture because it demonstrates how much precision we can get with the anterior total hip. The hip that I've replaced, I've used those little yellow lines. The distance that the hip is from the body is exactly the same on both sides to within as close as I can measure it, and the limb lengths, as measured by that red line, are within a millimeter. So this patient will never notice any change. What she will notice is that the hip doesn't hurt.
And so, does this patient need 2 hips, or?
She's getting there, but not quite yet.
And how often do you have to replace both hips?
Fairly commonly. But I will say a lot of patients come in, you know, with knees. They come in and they say, I've got terrible arthritis in both knees. What do we do? Say, just replace one at a time. Because if we can give you one, you know, good side, the other side becomes a lot less symptomatic, and we can put off a second procedure for longer.
How long do you usually wait between replacements on either side?
If they really want them both done, as little as 6 weeks. But in a very real sense, I work for the patient. I give them options, and they tell me what they want to do. So if they say, you know, I want to hold off, we hold off as long as we can. If they say they want to do it, as long as it's prudent and reasonable, we'll do it.
So when you do a total hip, this is a total hip, the bottom and the top. Are there any partial hips? Do you do partial hips?
Yes, but only in the context of hip fracture and injury and things like that.
If I fall and I break.
Yeah, correct. So I tell all your viewers, you know, especially this time of year, we have an epidemic of hip fractures. Please, 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 just be careful.
From the ice, from falling on the ice?
Exactly.
Oh.
Yeah, exactly. You know, I think this time of year, our waiting room kind of looks like a Civil War battlefield with everybody sliding on the ice and whatnot. So
yeah, I've heard a lot of complaints. So okay, posterior versus anterior. Posterior, you have to cut the muscle. That sounds like a lot of healing.
It is.
And a lot of change in your body.
It is, and there's a lifetime risk of dislocation. You have to use a pillow between your knees for 6 to 8 weeks. And you know, there's a lot of variations. There's a lot of ways in. And if someone has had a great experience with a posterior hip, I would not try to dissuade them from going to the same surgeon. I mean, there are people who have been doing this for 30 years and do a great job. But I think for me, I can offer people the most precision, the best outcomes, and the most reliability by going in the front.
Would you say that most candidates for hip replacement are also candidates for an anterior approach to the hip replacement?
It is by far and away the exception that people would not be. But again, you know, I don't claim to have a monopoly on all that is true about orthopedics. I just know what the literature says. I know what has worked for my patients. And I also think that when you're talking about a quality of life procedure like this, the less we can impede on people's quality of life after surgery with restrictions, with pain, with recovery, that has a lot of conceptual appeal to the patient as the healthcare consumer.
What are the after effects of an anterior versus posterior? Are they different?
2 years out, the literature shows us that the effects are very similar. But how quickly people get to that positive endpoint is much more reliable and much faster going in through the front.
So through the front, you have less risk of dislocation.
Correct.
You have greater healing.
Correct.
You have less, I don't know.
Less,
you don't
less
have to
muscle.
sleep with
Nope.
pillows under your
Less
your
muscle
legs?
damage, very few restrictions. Like I said, back 30 years ago, just dropping if you think about engines, naturally aspirated, carbureted engine worked just fine. Got you up to 80 miles an hour.
Yep.
But if you do fuel injection in a turbocharger, you're going to go a lot faster. So.
A different approach. But you both drive in the car down the road.
Correct.
Mm-hmm.
But one's more efficient and one's more powerful. And I do think that this way of doing it is far more powerful.
Mm-hmm. What about knee replacement? Is it all the same thing? Is there any special front versus back on the knee?
No. That's a great question. A couple days ago, I had a patient come in who said that her mother down in Florida was going to a special surgeon down in Port St. Lucie, Florida, or some such place, who's doing a special approach to the knee. It just doesn't exist. You have one way in. It's through the front. It's parapatellar, and you can make it small.
Parapatellar? Does that mean this way?
Right in through the patella. There's one way in, and whereas my hip patients echo the sentiments that you shared, they say, "I wish I had done this sooner, and I feel pretty good." I tell my knee patients it's going to take you about a week to forgive me and about a month to be glad you had it done.
Right, because it hurts for the first. It hurts a lot for the first week.
It's sore. I mean, you're changing that joint in a very significant way. Once it starts to heal, once your body becomes acclimated to the new geometry, people get better. But I think.
Ooh, what is this? What is this? Slide. Can we pull up this slide on the screen so we can talk about this? What is this?
Well, rather than I wanted to include this. I think it's very tempting to. People want to get bogged down in the specifics and the mechanics. But what I really want to focus on is after we get through that mechanics, which, I'll tell anybody anything they want to know, but it's my job to do it right. After we get done with the mechanics of the procedure, how do people do? That's the most powerful question. That's why people, I think, want to go to Boston, because they believe that the brand they encounter, be it the Baptist or HMG or where I trained over at BI Deaconess, they think that brand somehow connotes quality, and it does, but maybe not in the same sense as it did in the past. For instance, these are my if you look at. If you look at the website, this is Heywood Orthopedics just before I joined. We had one Google review, and it was 1 star, right?
Yeah.
So if you just look at that,
one angry person.
If you look at that, what kind of impression of quality do you get? You don't get a good impression. If you click that review, it's actually from a guy that another surgeon operated on who had 2 knee replacements. He was thrilled with his knee replacements. He was unhappy that the staff didn't return his call one day.
Yeah.
So so I think if you look at that, you get a very negative perception. That's why I included the next slide, which is my website, which is where I actually report on my results. So in my previous practice in Georgia, I wanted to know how I was doing. So I hired somebody to call each and every one of my joint patients. We looked at how they were doing before, how they were after, with validated outcome measures, and reported on that. That's what people want to know. And I think star ratings,
Reviews,
like these sort of pseudo Yelp star ratings, they give you maybe a 30,000-foot view, but they don't answer the question you want. They say, how likely am I to do well if I go to you for care? That's what people want.
Real testimonials.
Maybe, but maybe not. Read those testimonials. Most of the testimonials are not about how well they did. They're about how well they got treated as people. And so I think that's extremely important. But I also want to collect the data. I want to give people data, and I think that's what the best places are doing, and that's what I'm trying to bring right here to North Central Mass. Right to Gardner.
Correct. To Heywood Hospital, which gets great reviews from everyone that I hear talking about Heywood Hospital.
Nowhere gets all great reviews, but our goal is to actually, we learn more from our unhappy, well, you're in politics, you learn more from your unhappy constituents than you do from your happy ones, right?
It's true. People say, why do you let people say negative things? Like, that's where we learn where we can get better.
Correct.
Is from the negative.
Correct.
The negative stories.
It's not easy to listen to, and sometimes people just vent. But I think if you take them seriously and you really try to look through some of the hostility and fear that people bring to a negative encounter with medicine, they have some valid points. One of my most unhappy patients was a retired process engineer who typed me out a 6-page letter, and you know what? A lot of the things he said were right, and we talked about it. I brought him in, and we fixed a lot of those things. They were pretty easy fixes, and now I'm doing his other side. So
that's pretty thoughtful.
Yeah. Yeah, but I think you get better if you find a standard against which to compete. Like if we're trying to compete against the best around here, well, people perceive the best as the Boston Hospital, so that's going to be our standard for patient engagement and outcomes. If you listen to the people who are least happy and try to build off their feedback, I think you make real positive steps.
So if people are watching this program and they're saying, hip replacement, it was suggested to me. Now, what are some symptoms of a joint that might be needing replacement?
With a hip, a lot of times it's not what you feel, it's what people tell you. They say you're walking weird.
Really?
Yeah, it'll be
you kind of limp.
It'll be a very subtle change in gait. It'll be I can't put on my socks anymore because I can't bring my hip up. I have trouble getting in and out of the car.
So it's not always pain?
Yeah. Oh, it's pain. It's dysfunction. It's stiffness. And we have
And is it largely due to arthritis?
Well, yeah, arthritis, bursitis, but there's a lot of things in the hip. When you're talking about, that's a great question. When you're talking about hip pain, it's a lot like real estate. It's all about location, location, location. So if folks come in and say, I've got pain right here, right in my groin, that's where the ball and socket actually lives. That's
right in the groin.
Oh yeah, that's usually hip pain. Folks come in and say, I've got bad hip pain. It's back here. That's not your hip. That's sciatica. That's your low back. That's a totally different treatment paradigm. And sometimes, folks just say, I've got pain over here. Sometimes that's as simple as doing an injection and not even talking about anything more than that.
Like a cortisone?
Correct. Correct. And I'm happy to have those conversations with people. We have a great relationship with our primary care referrers. I've been here for about a year and a half, and so I'd say probably 80% of the patients I see don't need me as a surgeon. They need me to send them to therapy. They need injections. They need things like that.
And then 20% of the time.
Yeah, we have a different conversation.
So and let's talk just anterior, because that seems to be the preferred approach. What does it look like for my? What do I need to become a candidate, and what does it look like my post-operative care?
Well, you are way too young to be a candidate. No,
yeah, well,
but I would say that
if I'm 50 plus, I assume 50 plus.
I would say that. The reason I started doing the anterior, though, in all seriousness, is people more in your our age demographic than folks who are 70 years old, right? When I was in the service, it was very, very hard to sit in front of somebody who was in their late 30s, who had been, beating up their hip with a congenital problem in service of our country, and say, I'm going to make an incision this big, I'm going to start cutting a bunch of the muscles you need to work, and then you're going to have to worry about your hip popping out of place for the rest of your life. And so that's why I started going in through the front.
Yeah, you don't make posterior sound good.
Well, I only do that because I made a conscious change. I think it has a lot of disadvantages, but when I have to do a revision, I go in through the back. I mean, it's still a very useful way to go in. I think being a candidate for a hip replacement surgery is very, very individualized, and I'd hate to give too broad a brush, but I think if a patient can look at their life and say, I've been told I have hip arthritis, and when I look at what I can and can't do, that hip is what is holding me back, that's when it's time to think about being a candidate for hip replacement, no matter what your age. The youngest hip I ever did was 21. It was this poor kid whose hip collapsed because of sickle cell disease. She did great.
Okay, so we have 2 minutes. Let's talk about what does it look like? What's my healing after the surgery?
The
surgery is only 45 minutes, no problem.
Yeah, 45 minutes, sometimes a little longer with the harder ones. But we close with, I trained as a plastic, before I was in orthopedics, I was training in plastic, so I close with a plastic surgery technique.
So you're all around.
There's no sutures to take out. We close it, we put just one little bandage over it about this big.
There's no sutures?
Nothing to take out, no. There's nothing, everything's on autopilot. Correct. Everything's on autopilot, and we get people up, walking around the same day, and sometimes people leave the hospital the very next day. Yes, ma'am.
And then do they not, can they drive? Do they have to drive with their other leg?
Driving is more about your hip and your ankle than it is about your knee. Yeah, but you got to be off narcotics. You got to be walking without an assistive device, and that's again an individualized decision. But again, we get people back to where they want to be with that approach much faster.
Much faster.
Yes, ma'am.
Because isn't it like 6 weeks with a when you're going through the back?
Correct. And I have to say, it breaks my heart to have this negative slide up there the whole time we've been talking. In the last minute, could we advance to the very last one?
Can we switch out a better slide?
Maybe.
Right. No, not the, yeah, there, oh, here we go.
So I just wanted to sort of sum it up. My goal in medicine has always been to have the kind of practice and work at the kind of hospital where I would want my personal family, my kids, my wife, my extended family to go for care, and that's what we're trying to do here. You know, I think I trained in Boston. I get it. You know, it's a big name. There's a lot of gravity, but my goal has always been to bring that same level of care and that same level of customer service and respecting the patient and giving them what they want. Bring it right here where I'm practicing. That's what we're trying to do, and I'm so grateful for you giving me the opportunity tonight to talk a little bit about that.
I'm so glad that you came on and told us all about total hip replacements. I learned a lot myself. And if you think that you might be a candidate, you can contact Dr. Holman at Heywood Orthopedics at Heywood Hospital.
Correct. And